Welcome to Advanced Practice, where we brew together the latest thinking in mental health practice. This content is for educational purposes only and does not constitute medical advice, diagnosis, or a prescription. Clinical decisions should be based on individual patient assessment and established professional guidelines. This is the premiere of our new series on antipsychotics. In this introductory episode, we lay the groundwork by exploring the evolution of these treatments from typical first-generation pioneers to the atypical second-generation staples. Whether you are curious about their use in schizophrenia, bipolar disorder, or as augmenting agents for depression, this series will provide a clear evidence-based roadmap to understanding how these powerful tools shape modern mental health care. To understand the clinical profile of antipsychotic therapy, one must master the nuances of the dopamine hypothesis, which serves as the pharmacological framework for both therapeutic efficacy and the pervasive adverse effect profiles we manage in practice. The classical hypothesis states that the positive symptoms of psychosis, the hallucinations and delusions, are the result of dopaminergic hyperactivity within the mesolimbic pathway. By utilizing dopamine 2 receptor antagonists to achieve a receptor occupancy of approximately 60 to 70%, we can effectively manage these symptoms. However, the lack of regional specificity in current compounds leads to collateral blockade across three other critical dopaminergic tracks. The most immediate clinical concern involves the nigrostriatal pathway, our primary motor circuit. When D2 blockade in the striatum exceeds the 80% threshold, the delicate balance of the basal ganglia is disrupted, manifesting as the spectrum of extrapyramidal symptoms in the form of dystonia, akathisia, and secondary Parkinsonism. Simultaneously, we must monitor the tuberoinfundibular pathway, where dopamine serves as the physiological prolactin inhibiting factor. Antipsychotic-induced blockade here removes this inhibition, leading to hyperprolactinemia. This can result in galactorrhea, gynecomastia, and long-term bone density loss due to hypogonadism. Furthermore, their broad receptor affinity beyond the dopaminergic system causes more side effects. Blockade of histamine 1 and serotonin 2C receptors is a primary driver of the rapid weight gain, dyslipidemia, and insulin resistance that characterize metabolic syndrome, particularly with second-generation agents. Perhaps the most critical of these adverse effects is neuroleptic malignant syndrome, a rare but medical emergency characterized by the clinical tetrad of mental status changes, muscular rigidity, hyperthermia, and autonomic instability. Pathophysiologically, NMS is thought to result from a profound and rapid reduction in central dopaminergic activity, leading to a breakdown in the hypothalamic thermoregulatory centers. This failure can result in severe pyrexia, often exceeding 38 degrees centigrade or 100.4 degrees Fahrenheit, and is frequently accompanied by a marked elevation in CPK and leukocytosis. Thermoregulation dysregulation is not limited to NMS, because antipsychotics also possess anticholinergic properties and interfere with hypothalamic function. Patients may experience impaired sweating and a reduced thirst mechanism, significantly increasing the risk of heat stroke during periods of high temperature or strenuous exercise. Conversely, in cold environments, the risk of hypothermia is elevated. These autonomic disruptions are often compounded by the blockade of alpha-1 adrenergic receptors, which can manifest as dose-dependent orthostatic hypotension, reflex tachycardia, and an increased risk of syncope, particularly during initial titration or dose escalation. We must also remain vigilant regarding the increased fall risk, especially in geriatric populations. Notable high-risk warnings include the risk of QTc prolongation, which can predispose patients to torsade de pointes and sudden cardiac death, particularly with agents like thioridazine or ziprasidone. Furthermore, many antipsychotics carry boxed warnings regarding increased mortality in elderly patients with dementia-related psychosis, primarily due to cardiovascular events or infections like pneumonia. Other side effects requiring monitoring include sedation, anticholinergic effects such as xerostomia and urinary retention, and hematological abnormalities, most notably the risk of severe neutropenia or agranulocytosis associated with clozapine. By viewing the dopamine hypothesis as a systemic physiological shift rather than a localized psychiatric intervention, we can better anticipate these trade-offs and transition from reactive symptom management to proactive individualized patient care. That's it for today. Subscribe to our channel and get notified for new videos on pharmacology reviews in the next few days. See you soon!